Hello, my name is Rachel Sass, and I'm a personalized prescribing clinical pharmacist at Genelex. Today I'll be presenting to you the introduction of Factor V Leiden and Factor II 20210A gene mutations to our panel. Our vision at Genelex is to apply the most comprehensive personalized prescribing systems possible to improve care, save lives, and reduce costs. Let's begin the presentation by discussing the normal functions of Factor II and Factor V. This slide illustrates the coagulation cascade. Factor II, otherwise known as prothrombin, is activated to thrombin in response to injury to blood vessels. Thrombin then converts fibrinogen to fibrin, which ultimately forms a clot. Factor V has two functions in the coagulation cascade. Its first function is to assist in making a blood clot, much like Factor II, and its second function is its interaction with activated protein C to halt the clotting process. Activated protein C normally inactivates Factor V by cleaving it at specific sites, and this inactivation slows down clotting. The Factor II mutation is a mutation that results from a single base pair substitution at position 20210 on chromosome 11. This mutation causes increased prothrombin generation, which increases the risk of blood clots. The Factor II mutation is autosomal dominant, meaning you only need the mutation from one parent to inherit the condition. Those that are Factor II negative have two normal alleles. Those that have the Factor II heterozygous polymorphism have one normal and one abnormal allele. And those with the Factor II homozygous polymorphism have two abnormal alleles. The Factor V Leiden mutation is a bit different than the Factor II mutation. It is a mutation that results in a single amino acid replacement at one of three available activated protein C cleavage sites. Activated protein C can no longer cleave Factor V at that specific site, which results in Factor V being inactivated approximately 10 times slower than normal. So thrombin continues to be generated, and this places the patient at increased risk of blood clots. Factor V Leiden is also inherited in an autosomal dominant manner. Those that are Factor V Leiden negative have two normal alleles. Those that have the Factor V Leiden heterozygous polymorphism have one normal and one abnormal allele, and those with the Factor V Leiden homozygous polymorphism have two abnormal alleles. The Factor V Leiden mutation is most frequently seen in the Caucasian population at a rate of 5%, and the Factor II mutation is seen most frequently in the Caucasian and Hispanic population at a rate of around 2%. The mutation occurs less frequently in other ethnicities as shown here. One important thing to note is that the Factor II and Factor V Leiden homozygous mutations are infrequent and occur at a rate of 1 in 10,000 for Factor II and 1 in 5,000 for Factor V Leiden. These mutations are most strongly associated with a first venous thromboembolism, or VTE. Association between recurrent VTE and these mutations has not been established. Other disease states associated with the Factor V Leiden and Factor II mutation include pregnancy complications and more rare complications such as idiopathic osteonecrosis. The largest amount of evidence of risk of venous thromboembolism in these mutations are with estrogen-containing oral contraceptives, estrogen-containing hormone replacement therapy, and tamoxifen. These medications alone are associated with increased risk of venous thromboembolism, but current evidence shows that the Factor V Leiden and Factor II mutations may further increase the risk. Specific recommendations for management are listed here. One of the most important things to remember is that the decision to modify therapy should always be individualized, as the risk of venous thromboembolism is multifactorial and varies widely from person to person. Recommendations for testing for Factor V Leiden and Factor II vary between different organizations, and some of the more common recommendations are listed here. It is important to note situations in which Factor V Leiden and Factor II testing is not recommended, such as universal screening, routine screening before pregnancy, oral contraceptive use, hormone replacement therapy use, or selective estrogen replacement modulator therapy use, as a prenatal or newborn initial test, or as a routine initial test in patients with arterial thrombotic events. Factor 2 and Factor 5 will be part of a 3-gene cardiology panel in conjunction with MTHFR to identify potential genetic risk factors for thrombosis. I want to thank you for listening to this presentation on new additions to the UScript Personalized Prescribing System. As always, if you have questions or would like more information on this subject, please call us at 877-431-4362 or send us an email. Thank you.